So just looking at medical imaging for pain in the cancer patient, plain x-rays are still important. So particularly for bony disease, and if you've got one site that's actually affected, particularly weight-bearing sites, then one may need to go on and do multiple x-rays just to make sure that there's not just one side affected by bony disease. Obviously, fractures can be picked up usually fairly clearly on plain x-rays, and then chest x-rays and abdominal films looking for evidence of chest infection, perhaps even pneumothorax, and then abdominal films looking for confirmation of bowel obstruction. Ultrasound is a good investigative tool because you can actually do the investigation without injecting contrast or the patient having to actually swallow contrast, which can be difficult in some circumstances. So one can ultrasound the liver and biliary tree, the kidneys, and the bladder quite easily. CT is probably the most commonly used modality for looking at patients with ongoing malignancy. And if there are special circumstances, then you can think about using MRIs, particularly for brain, spinal cord, and base of skull. Bone scans can be quite helpful, particularly if a patient is complaining of widespread aches and pains. And one would use this particularly in the setting of, say, prostate cancer and breast cancer. If there are suspicious lesions found on a plain x-ray or a CT or even an MRI, then a bone scan may be quite useful, particularly if the bone scan then shows up multiple lesions. If one suspects a pulmonary embolism, then obviously a CTPA is the imaging of choice, and the role of PET scan is really very limited in the palliative patient. PET scans would probably be used if there was a diagnostic issue or to look at staging disease much earlier on. The palliative patient may require ECG if they having chest pain that might be typical of ischemic pain, or possibly even to help give some confirmation to a diagnosis of PE if a CTPA was not thought to be warranted because of the patient's condition. Venous ultrasound looking for DVTs can be very useful, particularly because of the incidence of lymphedema in a lot of the patients with advanced disease. Endoscopy can be quite useful for patients who've got painful swallowing or any evidence of upper GI pathology. And of course, microbiology can be useful, particularly for urinary tract infections, to confirm the diagnosis, because this is something that's quite amenable to treatment with antibiotics. I'm just going to talk a little bit about the management of cancer pain. So initial management depends on the diagnosis, which hopefully we will have. So, for example, the treatment of bony metastases per se will be quite different from a patient who actually presents with a pathological fracture. Both will involve the use of analgesics and perhaps radiotherapy. But if a patient has a fracture, particularly of one of the long bones, such as the femur or the humerus, then certainly to get good symptomatic relief, then orthopedic expertise is going to be needed. So with any pain which is not controlled at presentation, one aims to get some immediate relief with analgesics of one sort or another. And if the pain is significant, then you're probably going to be looking at using opioids. So the initial management, if a patient presents, will depend on a number of factors. So it does depend on the severity of the pain, and we can ask the patient to try and grade how severe their pain is in different ways. It'll depend on what medications they've been taking for their pain, and obviously depend on the type of pain, and that's up to us to try and make the diagnosis of whether we think it's predominantly nociceptive or neuropathic, and sometimes it can be a mixed pain, which can make things a little bit more challenging. What we give the patient initially will also depend on whether the patient can take drugs, particularly orally. So oral is usually the preferred route of administration, but if the patient has a bowel obstruction or has been vomiting for other reasons or even has nausea, then the parenteral route may be much more appropriate. So this is a case history of a patient, a 77-year-old fellow with prostate cancer and known bony metastases. PSA is significantly elevated at 47, and the patient is complaining of increasing bone pain, particularly in the thoracolumbar spine and hips. So the pain on a scale of 0 to 10 is 6 out of 10, which means that the pain is moderately severe pain. Current medication is Panadine Forte, and the patient is averaging 4 to 6 per day. So what other information would we like to know about the patient? What other information is going to help us in terms of treating the patient? So on history, the patient has no allergies, so that means we can use a wide range of drugs. Appetite's poor, sleep's poor, mobility's poor because of the pain. The patient has urinary hesitancy, presumably because of local prostate disease. There's no nausea and vomiting. There has been problems with constipation. There is some bony tenderness on examination, but no neurological symptoms to suggest spinal cord involvement. Social history: the patient is married, lives at home with his wife, has 3 children, but they're not able to help, and is on a pension. So some of the things we can do in the initial pain management once we've started treatment: it's good to know what sort of response the patient's having. So a pain diary can be very, very helpful. It would be very reasonable in bony disease to commence the patient on regular simple analgesics like paracetamol, and if that's not effective, to look at anti-inflammatory drugs such as the non-steroidal anti-inflammatories or a glucocorticoid. If we are going to look at starting regular opioids, remember to start the patient on laxatives. This patient may still have other options in terms of anti-tumor therapy, and there may be other options as well, particularly thinking about radiotherapy. So if you're starting a patient on an opioid, then you need to warn them about a number of things, particularly the gastrointestinal side effects, adverse effects, so nausea, vomiting, and constipation. If the patient has significant pain in their back, remember about the possibility of spinal cord compression, and as I've already mentioned, remember that radiotherapy can be extremely useful if the pain is not settling fairly rapidly. Warn the patient about gastroesophageal reflux or epigastric pain, particularly if you've commenced a non-steroidal anti-inflammatory drug. And the patient, if they're still having ongoing issues, needs to be reviewed fairly promptly, either by yourself or one of the nurses. Neuropathic pain is, as I've already alluded to, a difficult problem for patients. The World Health Organization classification breaks it down into nerve compression pain, nerve injury pain, and sympathetically maintained pain. So the pain is located in an area where there's no tissue damage and is attributable to dysfunction or injury of a neural structure. And there are various terms used to describe neuropathic pain. The pain can be dysesthetic, which can be a burning or prickly type of pain, or classic paroxysmal pain, where it feels like an electric shock or a shooting pain, and it comes in basically in pulses. It can also be associated with sensory changes such as numbness, motor changes, obviously like mild to moderate weakness, and perhaps even autonomic dysfunction. So a bit of basic anatomy: pain and temperature sensation come via free nerve endings and travel via C or delta nociceptive fibers. So nociceptors are normally inactive, but excited by mechanical, thermal, or chemical stimuli, and obviously in the setting of cancer pain, then this is usually mechanical, but could possibly be chemical as well.